See me, right?
Yes.
Okay. Okay. Well, hi everyone. Thank you for joining this webinar today. I'm excited to talk about this topic that's very important, and I hope that it's beneficial to you. So, we're going to be talking about why do I have hypothyroidism. It's going to be a closer look at Hashimoto's. So a little bit of background on me very quickly. I am an internal medicine trained physician and did my residency in New York City. I then worked in a large hospital system in New Jersey as a hospitalist or an inpatient physician. And, I was in the system seeing about 18 to 20 patients a day, um, often getting to spend 2-3 minutes with each patient, not a lot of time. And I was really kind of disheartened by that model. And so a couple of years later in 2019, when I moved to Austin, that's when I started my private practice, which is aiming to provide a more holistic approach to chronic disease. So that's kind of a background on me. And so I'm going to dig into the topic. And what I'm going to try to do is I'm going to try to talk for maybe 25-30 minutes and be respectful of time. And then any questions that come along, please put them in the chat box, and we'll give some time at the end to speak on questions, either in the chat or if you want to unmute yourselves and ask any questions. So why are we basically talking about Hashimoto's? Well, when you're diagnosed with hypothyroidism and you see your physician, you're often not told why you have the hypothyroidism. So in 90% of cases of hypothyroidism, it's actually due to Hashimoto's, which is an autoimmune condition. And as the title suggests, autoimmunity is the most common cause of hypothyroidism. So it's very important that we discuss this. Now, Hashimoto's mostly affects women 20 to 60 years old, although that age is getting younger and younger that they're first being diagnosed with it. And women are about 8 to 10 times greater risk than men for developing Hashimoto's, although a significant number of men still develop it. It's estimated around, conservative estimates suggest around 14% of the population suffer from Hashimoto's, although there are some studies that suggest that there can be, that number is actually an underestimated number if you take in a lot of the preclinical or the patients that don't have symptoms who have Hashimoto's. And it's the most common autoimmune condition in the world. So that's another important reason why we're discussing it. So now, just to talk a little bit about the history and background of Hashimoto's, it was discovered by a Japanese physician in 1912 by the name of Haraku Hashimoto. He was 31 years old. He was a pathologist. He published a paper about lymphomatous goiter, which was an inflammatory response in enlarged thyroid glands. He published it in a German medical journal, and this was picked up in by other physicians, American and British, and it was translated into English. And this phenomenon came to be known as Hashimoto's, what he observed. But little did he know that it would, in about 100 years later, become one of the most common or the most common autoimmune condition in the world. So the symptoms of Hashimoto's and hypothyroidism are, there are a lot of symptoms because it affects virtually every cell in the body. So you can have fatigue, you can have chronic constipation, you can have weight gain, decreased metabolic rate, a loss of your outer third of the eyebrows, a slowing of the heart rate, neurological symptoms such as brain fog, difficulty focusing, depression, menstrual irregularities, and it's a common cause of infertility as well. So these are all the symptoms generally associated with the hypothyroidism, low thyroid function. There are also related to this, but I didn't put it up, symptoms of hyperthyroidism, such as palpitations, anxiety, difficulty sleeping, insomnia, and so on, which are symptoms that you can see fluctuating between, because there's a lot of patients that go between hypo and hyper symptoms as well. So just important to remember that you can have a myriad of symptoms in both hypo and hyper with the same condition, Hashimoto's. Now, the diagnosis is made with antibodies that are in your system to something called thyroid peroxidase, so TPO. TPO is an enzyme in the thyroid gland that is involved in the production of T4 and T3, your thyroid hormones. And when you have antibodies developed, when your immune system develops antibodies against this enzyme, and you can test that in the blood, that confirms the diagnosis of Hashimoto's. And it's a pretty good marker of Hashimoto's. They found about 95% of patients with Hashimoto's have this thyroid peroxidase TPO antibody positive, but it's rare in healthy controls. So it's a very good test, and you're not going to have a false positive, generally speaking, on that. There are other antibodies like antithyroglobulin antibodies. These are also good to test. They are, however, less sensitive, found in approximately 60 to 80% of the time. So if you just had to run one, the better option would be to do a TPO antibody. And that's basically, and that and antithyroglobulin is what I run myself in my clinic. So, and I'm going to get into a little bit more about why these antibodies are so important in the next slide. So this graph really illustrates very well the different nuances in testing. And what I mean by that is that you often, what ends up happening in the conventional medical model is that you go and you just get your TSH checked, or the provider just checks your TSH, which is your thyroid stimulating hormone. And on the basis of that, they will decide whether you are hypothyroid or there's something wrong, or you're absolutely normal and there's nothing to be worried about. So the problem arises that because the nature of the illness is that it's fluctuating, you sometimes have a normal thyroid stimulating hormone, sometimes you have it high, sometimes low. So if you were to get your blood level checked at this point or at one of these points where it's normal, you'd be told by the physician that there's nothing wrong with you, when in fact you just have a normal TSH, yet you have an underlying autoimmunity, underlying Hashimoto's present. So it's very important for people to look at the entire picture. And it's only when they really get tested at this high TSH that they get diagnosed with hypothyroidism. And that too you might not have the antibodies tested, so you may not have a Hashimoto's diagnosis, but that's very important to remember. Now, when I spoke on TPO antibodies in the last slide, the important thing to remember is that people often think that TPO antibodies correlate exactly with your severity of disease. And I'm going to explain in the next couple of slides how that's not actually the case. So this is the linear model I was talking about. This is basically the existing model that exists in most healthcare practices where TSH is the only thing that's checked. You are found to have, if you're found to have a high TSH, you're started on Synthroid or synthetic thyroid hormone replacement. Generally, every 6 to 12 months, your TSH levels are repeated, and your physician or provider is going to adjust the dosage based on that. And that's really all that happens for the most part. And on the other hand, your other symptoms like depression, anxiety, menstrual issues, they get managed with other medications like antidepressants, oral contraceptives, and so on. So that's the model that exists right now. And it's really not a sufficient model to treat a lot of these patients. So that results in basically 3 types of patients that I generally see coming through, which is patients that are new to the system altogether. And these are patients that just had an onset of symptoms or just had routine labs done in which they were found to be hypothyroid or have Hashimoto's. These are patients that oftentimes will respond very well initially because they haven't been placed on a thyroid hormone replacement. They haven't been given a lot of interventions. So generally they have a period where they can do very well, at least in the beginning. And then there is the patient who has had a lot of conventional care. They've been on thyroid hormone replacement maybe for many years with varying dosages, but not a lot of care in the alternative world of diet, lifestyle, other things that someone has looked into more deeper. And these are people that, despite being on thyroid hormone replacement, and seemingly having normal blood levels, they are still struggling with symptoms and have not been able to find the relief they need. And then you have the patients at the end, uh, which basically have had a lot of conventional physicians, conventional therapies, and as well as some alternative care, and they're still struggling with symptoms. And that might be a scenario in which not enough depth has been paid to that, or not enough care and attention has been paid to that individual who, in terms of their particular triggers and what might be causing their issues. So, it's the first two. They're still relatively new to the alternative healthcare world, and there's a lot to do. It's the latter uh, type of patient that is very important that we get to and address as well, those that are struggling despite doing multiple things. And that's why, I try to use a very complex and detailed model of care when dealing with these patients. Okay, so I want to just go over basic thyroid physiology so that everyone can understand when you get certain blood tests done or what exactly is going on inside you. So if you look in this diagram, you'll see the TSH, the thyroid stimulating hormone that we talked about, that gets released from the pituitary gland in your brain, which responds to low or high levels of T3 and T4. And so T3 and T4, that feedback loop is basically what is affecting your TSH levels, and the TSH then stimulates the thyroid gland to then produce thyroid hormone, the majority of which is T4. About 90% of the cases, or 90% of the hormone is T4, and it's T4 that actually provides the negative feedback loop to the thyroid gland, which then regulates the TSH amount of secretion. T3, on the other hand, is about 10% produced in the thyroid gland or from the thyroid gland. And eventually this T4 actually gets converted into T3, which is your active thyroid hormone. So T3 is the hormone, the type of hormone that is active, that does all the metabolic effects, that is eventually converted from T4 into T3 by an enzyme called 5-deiodinase. Deiodinase meaning a removal of an iodine group from the molecule. And the majority of this T3 is actually bound to protein. And so it's protein bound. It's not free to act and be metabolically active. But about 1%, 0.5 to 1% is free T3. And this free T3 is the one that eventually goes and binds to the receptors on virtually all your cells in the body and leading to metabolic activity. So that's a quick rundown of the physiology. But the reason I mention this is because it's very important to know where Hashimoto's can affect you and where it can cause problems, and why sometimes, it'll help explain why a normal blood test, why you have normal blood levels despite having symptoms and not responding very well. So the first mechanism is where you have autoimmune destruction within the thyroid gland as a result of the TPO antibodies. So an autoimmune response against the TPO and thyroglobulin antibodies that results in a destruction of thyroid hormone in the thyroid gland. Sometimes this can actually cause a spillage of thyroid hormones into the system, which will actually make you, for a period of time, hyperthyroid. So sometimes you can have palpitations and anxiety and all the things that come with hyperthyroidism. So that's the first and probably the most significant area of thyroid destruction with Hashimoto's. But there's a second, which is the conversion of T3, the T4 into T3 by this enzyme. Inflammation in this area can actually affect this process. So now you may be looking at a normal TSH, a normal T4, but low T3 levels. And the reason is because not enough is able to be converted into T3. And that's another, very significant, finding, and important to look at that when you're looking at your actual blood levels. And the third area that it can affect is not in this whole process, but actually at the areas where the thyroid hormone binds to the receptors, the thyroid receptors, and it can actually alter the shape of those receptors. So you can have absolutely normal T4, TSH, free T3 levels in your blood, yet you're still having symptoms, your thyroid is underactive. It's because the effect is at the level of the thyroid receptors. So those are very important things to remember. Now, I was going to speak very briefly. A few minutes ago, I mentioned that the TPO antibodies that people see in the blood, which can range from anywhere from about 40 to in the thousands, people often think that that correlates very closely with the severity of their Hashimoto's. For example, I may have a TPO antibody level of 100, and the next person might have a level of 600. That doesn't mean their Hashimoto's at this point in time is worse, because the TPO antibody levels are just an indication of, again, when it's antibody levels, the antibodies itself don't attack the thyroid gland. They mark the protein that eventually causes the immune system and the T cells to come in and have a strong immune reaction and cause thyroid destruction. So it's important for your own self as a baseline. So for example, if my levels go from 400 to 200, I'm probably doing better in my Hashimoto's control, but that doesn't mean that if I have a level of 100, I could still have a severe autoimmune reaction because of the T cell activity versus someone who has a level that's maybe 1,000, but symptom-wise, they're doing okay. So I wanted to point that out because that's a common misnomer that people feel like, my antibody levels are so high, why do how does that explain that I'm doing fine? Or on the contrary, my antibodies levels are so low, and how does that explain how bad I'm feeling? And this is the reaction that occurs within the thyroid follicle cells. The thyroglobulin protein plus the iodine molecule with TPO, thyroid peroxidase enzyme, will go and make T4 and T3. So that is on the thyroid physiology. Just a slide to show you histology, meaning when you look through a microscope. So here you can see that there are areas where there's healthy thyroid cells, thyrocytes. These sites are healthy and good. And then you can see areas of destruction, areas that are affected. And this is what a thyroid gland with Hashimoto's is going to look like on histology. So that brings us to how should we look at Hashimoto's, and what I'm trying to essentially do differently, which is the linear approach that I talked about initially, which is oftentimes not working. It's too simplistic. It doesn't take into account all of the various mechanisms that we know that patients with Hashimoto's get affected by. So we have to really go away from the linear approach and go more towards a web-like approach, or an approach that looks at Hashimoto's as more of a multi-system disease as opposed to a specific thyroid issue. And when you start looking at Hashimoto's as a multi-system disease, then you can treat it as such, and you can add that complexity and nuance. So that's the complex web that you have to treat Hashimoto's with. And with that, it's important to understand that there are these different webs of Hashimoto's that affect virtually every system in the body. And oftentimes patients have these symptoms that are coming from various different places, and they don't understand why or what the mechanism is of these symptoms and how they're affecting a specific system. So I wanted to mention briefly, and in the clinical approach that I think is most effective and should be used by pretty much everyone, the idea is to identify what your particular web and issue is as a patient, and then for the practitioner and the patient to work together at unraveling that and fixing that particular web. So we start, and this is going to be very brief for the sake of time, the Hashimoto's neurology web. So a lot of patients suffer from neurological symptoms related to Hashimoto's, such as fatigue, brain fog, difficulty focusing, difficulty concentrating. They can't do activities for a long period of time, like driving, things like that. And on a more severe level, it is things like seizures and more cognitive decline, and those types of things can also happen. The reason for that is because the TPO antibodies that we talked about previously, they actually cross-react with certain cells in your brain called cerebellar cells that are often responsible for balance and other functions. So there's a cross-reactivity, which means that these same immune cells that we think are just attacking the thyroid are also going to your brain and attacking those for immune system destruction eventually and problems down the road. So there's that. There's also an increase in your cytokine production as a result of inflammation, and this causes more neuroinflammation or brain inflammation. So that's how some people get these symptoms. And the other important thing to note is that when you have Hashimoto's, you can actually develop other antibodies that go and attack the brain as well. So the Hashimoto's neurology connection brain connection is very, very important to note. On the GI side of things, it's very important to note that your intestinal motility can be reduced with Hashimoto's. Your bacterial overgrowth, or something we call SIBO, small intestinal bacterial overgrowth, can occur. There can be, again, dysbiotic bacteria, so an imbalance between good and bad bacteria. Your gallbladder contractility can go down. That affects it can lead to gallbladder sludge, stone formation, things like that. Eventually you can have micronutrient deficiency as well in the GI system. So the connection with the GI is also very important. Your blood sugar can be affected by Hashimoto's can actually impair the insulin receptor site and cause insulin resistance. So you can have blood sugar imbalances. You can have female hormone imbalances, which eventually results in menstrual irregularities, infertility, immune system as well. You can have increased what we call intestinal permeability, which is where your the lining of the small intestine gets affected, and you have more permeability through which substances like larger food proteins and toxins, microbes get through. It can affect your liver and your toxin removal pathways, definitely, and microbiome as well, in conjunction with your GI tract. So all this to explain to you basically that there's so many nuances to the Hashimoto's story that we have to take into consideration. And so it's not just a simple thyroid issue. I also sometimes like to use an onion analogy, which is that with each individual patient, you have to peel back the layers. And, for some people, the superficial layers have all the answers where, you can easily figure out what's going on and you can treat accordingly. But in other patients, there's a need to pull back the layers and go deeper and deeper into that onion, so to speak. So that analogy as well. So where should the patient go from here? If there's someone, either you're suffering from Hashimoto's, someone who's suffering, inevitably, we all come across people that suffer from thyroid problems, specifically Hashimoto's. So it's important to be working with a provider that you can trust and collaborate with. Oftentimes there's a one-way connection with practitioners, and that's not something that works well for the patient. So you need someone who you can trust, you can collaborate with. You need someone who is willing to test broadly and see a full thyroid panel, for example, TSH, thyroid stimulating hormone, T4 and T3 total levels, which we saw in the diagram previously. Free T4 and T3 levels, this is the amount that's not bound to the protein. TPO and antithyroglobulin antibodies, which should really be done on every single patient in my estimation, because I tend to pick up a lot of patients that even if they don't have symptoms or they have a normal thyroid panel, you can actually pick up the fact that they have thyroid autoimmunity, because sometimes you can go about 7 years from the time of developing antibodies until you have symptoms and tissue destruction. Reverse T3 is something that that's a inactive form of a T3 that the T4 can go into. So sometimes you have higher levels of those in infections, inflammation, other causes. So you want to make sure you have a full picture of what's going on with the thyroid. And this is just thyroid testing. There's obviously other tests to do related to the whole body as a whole. Now, quick note on thyroid hormone replacement. If we have a patient that is actually hypothyroid, frankly hypothyroid, which means they have a true high TSH and they have a low free T4, low free T3 level, they should be on hormone replacement, because before you start diet, lifestyle, and other treatments, it is important to correct the thyroid levels. And it's going to be very difficult to put into practice to change anything or much of anything if you're not fixing the thyroid hormone deficiency to begin with. So that's something very important to remember, because there's a lot of people that will just not want to be on medications, and it's understandable to a degree, but there is a time when it's important to be using thyroid hormone replacement, especially if you're very low and you're hypothyroid. Thyroid hormones, especially Synthroid, have actually been shown to have a protective role above and beyond just simply correcting your thyroid levels. So they actually have a role in modulating antioxidant levels. They provide a protective role, and they can improve the oxidative stress which you otherwise have with hypothyroidism. That's why when people go on it for the first time, initially they have this period of feeling very, very good on thyroid hormone. And the reason is not just because their hypothyroidism is fixed, but also because that inflammation is calmed down and that antioxidant level has improved quite a bit. So that's important to note about thyroid hormones. Now, I've included a list of brand name and generic thyroid hormones. There are different ones. There are synthetic ones. There are bioidentical ones. There are ones with T4 only, some with T3 only, some with a combination of the two. What you'll generally see is that you'll see most conventional providers using Synthroid or levothyroxine, which is a synthetic T4, and you'll see a lot of alternative practitioners using the, more of the bioidentical ones like Thyroid and Thyroid. And people have preferences. Each person has a preference, and sometimes patients are on this journey to find which is the best one for them. The truth of the matter is that there is no one size fits all, really. There are some pros and cons to each of these. For example, some are covered by insurance, others are more expensive. For some people, they may not be able to tolerate T3. And so if you give them a T3 or a combination of T3 and T4, they may do worse if they're more sensitive to T3. So it's not so much as to which is the perfect one and to be on this journey and quest to find the perfect one, but it's more so about, patient by patient, what is the best that works for them. And then also to realize all this whole web that surrounds it, so we don't become too fixated with hormone replacement. We just try to, get the levels in good control and then focus on everything else related to Hashimoto's. Okay. I'm just going to take a look at the time and try to wrap up soon. So dietary considerations is very important. So there are certain things that you want to look to restrict and certain things that you want to modify. So when we talk about restrictions, we have gluten, for example. Gluten as a molecule has a very significant cross-reactivity with the thyroid gland. In other words, the gluten molecule looks very similar to the thyroid gland. So the immune system, which is already working against the thyroid gland, when it sees the gluten coming in, it actually will rev up and it can cause thyroid destruction as a result. So gluten is something generally that patients with Hashimoto's should avoid, and you can often have an improved reaction or improved health with removing gluten. Iodine is the other one that I wanted to mention, and this one doesn't get too much mention because there is somewhat of a controversy in the world of thyroid and Hashimoto's, where there are some people that will recommend and supplement with iodine to feel that it actually improves thyroid function and Hashimoto's. The bulk of the literature says that iodine restriction is actually shown to be beneficial in Hashimoto's thyroiditis. So restricting iodine as a supplement, and even some studies that show restricting it as a dietary ingestion is important. Now, just a quick note on that is that, yes, iodine is involved in the pathway that forms the thyroid hormone. So you could think that more iodine actually would be beneficial. However, it's a very small amount of iodine that you actually need in order to synthesize thyroid hormone. But beyond that, excessive supplementation with iodine actually worsens oxidative stress and increases inflammation. So it's considered to be restriction around about 100 micrograms per day of iodine is actually shown to be beneficial. Lectins are the foods in beans, chickpeas, legumes, nuts and seeds. So they, for some people, can cause problems in Hashimoto's. Nightshade vegetables like tomatoes, potatoes, eggplants, they can cause problems. And there's the phenomenon of dietary protein cross-reactivity, which is important to mention, which is essentially that when a dietary molecule has the the same amino acid sequence as the thyroid molecule, for example, the immune system actually makes antibodies. It can make antibodies against that food, but which also then cross-react and attack the thyroid gland. So that's very important to note. In modifications, I mentioned microbiome diversity because what ends up happening when someone has Hashimoto's or any autoimmune condition, and that you're focused so much on restrictions, is that you tend to restrict a lot of foods and then you pretty much eat the same thing each and every day. And ultimately your microbiome suffers as a result, and you have a lack of diversity in your microbiome. So the aim should always be to broaden microbiome diversity, and that can be done by incorporating as many plant fibers into your diet as possible, which will eventually increase bacterial diversity, and that eventually is the best for long-term health. Sodium intake I wanted to mention briefly because sodium intake has been shown, higher sodium intake has been shown to also worsen Hashimoto's thyroiditis. And dysglycemia, which refers to blood sugar imbalances, is critical because oftentimes someone comes in and their issues are actually blood sugar issues. And so when because we talked about blood sugar issues a little while ago, but if you fix that, you'll take care of a lot of inflammation that is going on because they fluctuate between these pathways of hypoglycemia and hyperglycemia. And oftentimes they need to manage that before they can control the other inflammation in their body. Environmental considerations to mention quickly. One take home here is bisphenol A. That's probably the most common one so, whenever we look at Hashimoto's, it should be there's a strong genetic component, yes, but you need something in the environment to turn on those Hashimoto's genes and for that person to eventually have Hashimoto's develop. So, and then for it to be triggered down the road. So bisphenol A is probably the most common. It's a component of plastics, and it's often wreaking havoc on these patients. Pesticides, another one, and then there's a list of other environmental agents that can trigger Hashimoto's. I want to go through lifestyle considerations as well. So the three key ones that I always focus and emphasize on is, one is stress, and the studies that show that people that are working on stress reduction will have actually lower levels of thyroid function tests. In other words, lower TPO antibodies, lower TSH levels. Overall stress is going to help decreased stress is going to help your immune system. Sleep is another key one. So poor sleep quantity and quality can worsen immune system negatively, can affect it negatively and worsen autoimmunity. And sleep apnea, if you have undiagnosed sleep apnea, for example, can increase the risk of development of Hashimoto's. And again, there is different mechanisms explained for that. Exercise is another one where you want to get to the right level of activity and not overactivity, but a right level for you to be able to get the best physiological and psychological outcomes. And generally, the studies have shown that a moderate, good amount of physical activity will decrease inflammation in most situations. Nutraceuticals that have been shown to be beneficial. So the key ones are these ones mentioned here. Vitamin D is a big one. So vitamin D is less so a vitamin, but more of a hormone. It has strong immunomodulatory effects, and we want to make sure, and actually patients with Hashimoto's tend to have deficiencies in vitamin D more so than other people. So we want to make sure we aim for levels that are roughly 50 to 70 in a good optimal range for vitamin D. Myo-inositol is another one to help reduce inflammation. Selenium has been shown at a level of about 200 micrograms a day to help reduce inflammation and improve Hashimoto's. Glutathione, which is an antioxidant, because your autoimmunity, oftentimes it the pathways of antioxidants, they get depleted. Glutathione is one of them. So you want to make sure your levels of glutathione are boosted and they're at good levels, repleted. Oftentimes liposomal glutathione is a good replacement for that, and it has good absorption. Curcumin, resveratrol are other ones that can help reduce inflammation as well. And pathogen considerations. So when we talk overall about each patient as an individual, there are, when you as you peel back the layers, as I talked about in the Hashimoto's onion, there are certain patients that are triggered by different things, and so you have to, for the patient that is just not getting better, you have to dig deeper and figure out what might be going on. And so in this case, there are certain pathogen considerations. For example, Clostridium botulinum, Botox, as it's popularly known, which is considered by many as a kind of a medical marvel, and it can treat migraines and cosmetic purposes and all this stuff. But it's actually been shown to be linked to Hashimoto's and can be a potential trigger for Hashimoto's. So important to note that. And then you have certain gastrointestinal pathogens. I just want to briefly talk about H. pylori, which is when you can have, which colonizes your stomach, and you can have, as a result, gastric ulcers. You can have problems with heartburn, abdominal pain, things like that. So if you have Hashimoto's and if you have those upper GI symptoms, that can be a red flag that you have H. pylori, Helicobacter pylori infection. And the importance here is that it cross-reacts with thyroid hormone. So basically, antibodies against the H. pylori, which your immune system is making, is eventually going to negatively affect your thyroid gland and cause thyroid tissue destruction. So H. pylori is one. It can be checked with a breath test, and oftentimes using either herbal antimicrobials or prescription antibiotics, you can eradicate that. So that might be important in someone to eradicate. Hepatitis C is another one where it has a significant cross-reactivity with Hashimoto's. A lot of cases of, about half the cases of hepatitis C are silent, which means no symptoms. So you may not even know that you have it, and you could have that could be the driver for your Hashimoto's. So it's important to just consider these pathogens. Epstein-Barr virus is another one that people can have, and that's where you have to look into the clues. For example, you might have a situation like I mentioned with H. pylori, upper GI symptoms. That's a clue. You might have with Epstein-Barr virus, you might have elevated levels of white blood cells, specifically monocytes. Those can be a potential clue. Then you have to look into that and treat that. So very important to talk about that. So in conclusion, as we wrap up, I want to mention the kind of key points that are take-home points. That Hashimoto's is the most common autoimmune condition in the world. Its prevalence continues to increase, and its age of onset continues to decrease. So younger and younger people are getting affected. It has multiple pathways through which it causes inflammation. So this is important because it's not as simple, let's correct your TSH and you'll be fine. There are all these different webs involved, and you have to normalize your, or try to work to fix those webs as much as possible to be able to achieve relief and remission. Hashimoto should be considered a multi-system inflammatory condition instead of an isolated thyroid disorder and should be managed as such. So if there's one key takeaway that you can get from this is that Hashimoto's should be really considered as a multi-system inflammatory condition. And that's how we should be looking to manage it. And that's really what's necessary. And there's these hundreds and thousands of patients out there with it. Just you can go and see Facebook groups with thousands and thousands of people suffering from this. But there isn't this complex model that can help them in that regard. And it's important to work with a provider who can understand it, Hashimoto's as a complex web, again, just like I mentioned, and work to slowly untangle it, work to find out what are particular triggers for a particular patient. And this is unique to each individual. And if you can do so, then you can take those patients that are really suffering and hopefully get some relief. So with that, I want to thank you all for your time. And if you have any questions, please let me know either through the chat. If you want to reach out for more information, I put my website up. I put our email address up. You can feel free to reach out. And I hope this proved beneficial for you, for either if you're suffering or someone you know is suffering. So thank you. And with that, we'll do a couple questions.
Yeah, if you want to put the questions in the chat, you can do that. Or if you want to ask a question live here with Dr. Akhtar, you're welcome to unmute yourself. And then we did record today, so we'll be sending a follow-up copy of the webinar. And of course, you can always ask additional questions at that time if you don't have any today.
Mm-hmm. Yeah, and thank you, Jenny, for being part of this and co-hosting with me.
Of course.
Yeah.
Hi, Dr.
Okay.
Omar.
Yes.
Quick question. Maybe quick. So I mentioned to you in a private message that I have both. I was diagnosed with both Graves' disease, and then like last year, I have the markers for Hashimoto's, which is something totally new for me. And I was experiencing a lot of the symptoms that you had listed in your slideshow earlier. And specifically, I was gaining weight, which most of my life I have had a hard time gaining weight. So I knew something was up and was suffering from depression and brain fog. And so I figured something was up with my thyroid. So I got tests done, and it seemed like, and I guess my endocrinologist said that this can happen, that you can be both, have Graves' disease and Hashimoto's at the same time. And but I haven't done. She's never like altered my medication. I've been on the same dosage since I was 19, and I feel like I just kind of really navigate all of these things, like, you know, just because this is my life. And but I've tried. I have switched up my diet, and I had taken my lab. I'd done my lab work, and I had a little bit of a lower result, I think, in my TPO results. And so I just didn't know if you had any advice for a patient like myself. I know you don't know my whole history, but just from what I've shared, I've just been on this methimazole tapazole medication, and I know that wasn't mentioned. I didn't see that in your on your list. I always hear about Synthroid, but tapazole was the medication the doctor that I got diagnosed with initially put me on. So I don't know if you have any advice for me, you know, at this point.
Yeah, absolutely. So I wanted to mention, you know, it's good you brought up Graves, because I didn't mention that here because I was focusing more on Hashimoto's, that specific condition. But Graves, which is proved with a test called thyroid stimulating immunoglobulin, TSI. So patients that have high TSI levels are diagnosed with Graves that can coexist with Hashimoto's. So in one case, if you go back to this slide over here, this is showing you the areas where Hashimoto's can affect you. But if your thyroid receptors are being stimulated, that is actually an autoimmune condition in which your TSH levels will end up being low and thyroid hormone will be high. You have hyperthyroidism. That's kind of a Graves situation. So it's much less common than is Hashimoto's, but I do see it, and I do have patients that have both. So certainly not a unusual thing. And what you mentioned with your physician is that basically that same model. I didn't include methimazole or any of the other medications here, but essentially what it is when you check your TSH, and that's really most of what is checked. Then if it's high, you're started on Synthroid. If it's low, you're started on methimazole, and you're really not. You're just adjusted that, and your blood work is checked every so often. So you're someone that falls perfectly into this as a proof where this is really it. But with all these other symptoms, what do we do? And that's where it gets to, certainly following a lot of the stuff that I mentioned here. And if you followed it, that's great. But let me just, so the dietary considerations. But again, in your case, especially if you've had it for a prolonged period of time, it's about where your particular triggers are and what is causing your immune system to continuously overactivate and to try to find that. And it's not always easy to find that, but like when you talk about weight, for example, you'll always try to adjust thyroid dosages, and oftentimes you're not really going to get, I mean, yes, your weight might fluctuate as a result, but you could be on the perfect thyroid dosage and your weight still goes up. And sometimes that's because your inflammation is present and that hasn't been fully addressed or looked into. But there's all these considerations with the microbiome, with inflammation, and so on. So there's so many components. So if I had to give you a very short answer, it is that the deeper you go into it and look for your particular triggers, that is what's going to be important for you. Whether it's the lifestyle, stress triggers, sleep is a big one, whether it's environmental triggers, a pathogen present. So that's really where it's really good to work with someone that you can collaborate with and get really deep into this stuff, if that helps.
Yeah, thank you so much. I appreciate that.
Yeah, of course. Okay, so any other questions right now? And if not, we will stop here and I will send out a recording of this to everyone so that they have this and can refer to it later. And I know I threw out quite a few things there, but I want to make sure that it's beneficial and so hopefully people can get some good takeaways from here. So let me stop the share and we can stop recording here, Jenny. And